Thanks very much for that introduction, and I'm pleased to be back to be able to speak to this audience. And our audience today, as you may recognize, is a diverse audience. We have a group of family practitioners with us because today our focus is going to be on a practical approach to the diagnosis and treatment of some common hair loss disorders. I don't have any conflicts of interest about anything I'm going to talk to you today about, but what I'd like to review with you is a very practical approach to a patient with hair loss. We'll examine some very common treatments, how they're used, some contraindications, and the kind of advice you may counsel your patients on when considering these treatments. And one of the key messages that I'd like to give to you today is what type of patient do you need to consider referral to a dermatologist for further evaluation? So in many ways, the title of this lecture could be, what do I do? Hair loss, what do I do? From your patient's perspective, what your patient is looking for is how you can improve their density, how you can stop their hair loss, and how you can get them back more hair. Of course, from the perspective of the treating physician, the most important aspect is the diagnosis, because it's the diagnosis which then governs the type of treatment that's going to be used. And different types of hair loss disorders have different treatments. It would be rather convenient if all hair loss was treated the same, then the same types of treatments could be recommended universally, but they're not. Different hair loss conditions have different treatments. And really, when approaching a patient with hair loss, one of the first things that you want to determine is, are you dealing with a non-scarring hair loss condition, or are you dealing with a scarring hair loss condition? These are the two big groups of hair loss conditions. In the left side of this panel, you can see some examples of non-scarring hair loss. The key to non-scarring hair loss is that the follicular openings, or these pores, can be clearly seen when you examine the scalp. The scalp generally looks relatively normal in these conditions. In a scarring hair loss condition, which is seen here on the right side of the panel, the hair follicle openings are missing. The scalp appears smooth, rather like a skating rink. These are very typical of scarring hair loss conditions. And so when you first meet a patient with hair loss, it's important to form a differential diagnosis or some sort of differentiation between whether you're dealing with non-scarring hair loss or scarring hair loss. In many ways, what we're dealing with is two groups of conditions that are more common and less common. So interestingly, the non-scarring hair loss conditions tend to be the more common, and the scarring hair loss conditions tend to be less common. And so what really matters when you're evaluating a patient with hair loss? Well, these are the so-called 5 S's that I frequently use when evaluating a patient with hair loss. And it's these 5 S's which allow you to break down that list of those many entities in the more common group or the less common group into the actual diagnosis. So if you determine that you think you're dealing with a non-scarring alopecia, how do you then determine whether it's androgenetic alopecia or telogen effluvium or alopecia areata or tinea capitis or traction? The 5 S's is a tool that can help you to determine that. What really matters when you're dealing with a patient with hair loss is information on the sites that are involved. Is it the crown? Is it the front? Is it the back? What's the speed of the patient's hair loss? Is it fast? Is it slow? Does the patient look the same as 6 months ago? Do they look different? Do they have any symptoms like itching, burning, or pain? Are they taking any medications? And have any medications been started recently that can account for their hair loss? And finally, are they shedding? Are they shedding at a normal amount that all humans do, between 50 and 100 hairs every day? Or are they shedding excessively? And so when you listen to a patient's story and you gather all this information about the 5 S's, we can generally determine the cause of the patient's hair loss. So let's take a look at how we can put these 5 S's into actual practice. Let's begin with a focus on male patients. You know, the vast majority of your male patients who come through the door are going to be coming through the door with concerns about male pattern balding or androgenetic alopecia. Of course, a small proportion will have scarring alopecia, a small proportion will have alopecia areata, but the vast majority of your patients will have androgenetic alopecia. And so the approach that I would recommend you give consideration to would be this approach. It's a simple approach to dealing with hair loss in men. And the very first consideration is for you to decide, do you think this is male pattern hair loss? And if you think it's male pattern hair loss, then considering ordering some blood tests, a basic CBC, thyroid, iron panel, and then start treatment. And I'd like to encourage you to consider starting treatment with agents such as Minoxidil or Finasteride, or refer them for hair restoration. If you don't think it's male pattern balding, then give consideration to whether you think it's localized alopecia areata. And if you think it's localized alopecia areata, then order some blood tests and start treatment. And I'd like to give you some tools today whereby you can feel confident about starting treatment with agents such as topical steroids, Minoxidil, or beginning steroid injections. And if you don't think it's alopecia areata, then consider referral for treatment. This is a very simple approach to dealing with a patient with male balding, but it works quite well and gives you an algorithm for thinking about who to refer and who to begin treatment. So let's take a look at some prototypical conditions which involve specific sites on the scalp with hair loss. This is a patient who's 29 and is developing some hair loss in a very slow manner. But the key thing about this patient, when we go through these 5 S's, is the sites that are involved. This patient has hair loss starting in the temples and in the crown, and then the mid-scalp becomes involved as well. He's shedding a bit more than normal, but nothing too alarming, and he doesn't really have anything in terms of scalp symptoms. This is very typical of androgenetic alopecia or male pattern balding. And one of the key things about male pattern balding is that the hair follicles themselves, when you look up close, are becoming thinner. And we call this miniaturization. So male pattern balding is about both specific sites on the scalp that are involved, and when you examine those sites, the hair follicles are miniaturizing. The rest of the S's are relatively unremarkable. And so now that you have a diagnosis, how then to begin treatment? And as you think about treatment of male balding, and as we go through some of the treatments for male balding, I'd like you to give thought about how you would treat a patient who's relatively healthy, and how you would treat a patient who presents with a history of depression, and how you would treat a patient who indicates that he wants to start a family. Are there any differences in your approach? These are the treatments for male pattern hair loss. We think about non-surgical treatments and we think about surgical treatments. The 2 Health Canada FDA approved treatments are Minoxidil and Finasteride, and we'll come back to them. These are 2 treatments that are very important to have a basic approach to as you're thinking about how you treat male pattern hair loss, because they really are some of the first line treatments in male pattern hair loss. But for our other non-surgical treatments, there are a number of low-level laser devices on the market that can be purchased and patients can use at home. There are 5 randomized, double-blind, sham device trials which show that these low-level laser devices are better than placebo. So they do lead to some degree of benefit for patients with androgenetic alopecia and can be considered and are relatively safe. Platelet-rich plasma is also an option for treating androgenetic alopecia. The thing to remember about platelet-rich plasma is there's over 1,000 different protocols. So there's no one treatment for platelet-rich plasma. Platelet-rich plasma involves taking a person's blood, spinning it down to get their plasma, and then injecting this into the patient's scalp. And a number of clinical studies support that platelet-rich plasma can be effective for male balding. Scalp micropigmentation is a technique where the scalp is tattooed with small dots to reduce the see-through appearance of the scalp, and hair systems can also be used. Hair systems are not uncommon as a consideration for the treatment of male balding. Certainly the other non-surgical treatments are much more common, but hair systems involve shaving parts of the scalp and applying the hair system to the scalp with the use of an adhesive. Hair transplantation is an option for many men with androgenetic alopecia. Generally, hair restoration is considered in men over the age of 25 who are appropriate candidates, meaning they have a good donor area, are relatively healthy, and have relatively stable hair loss, meaning that they're not rapidly balding. So let's talk about minoxidil and let's talk about finasteride. It's very important for treating male balding that you have some understanding of these two agents. Minoxidil is a topical treatment. It was approved in the mid-1980s. There's minoxidil solution and there's minoxidil foam. Minoxidil solution at 5% is used 1 milliliter twice a day. It's more effective than 2% minoxidil. Patients rarely develop headaches, dizziness, and heart palpitations. Shedding can occur in the first month, but minoxidil is a reasonably good option. It helps about 20 to 30% of men, so it clearly doesn't help everyone with male pattern balding. The foam was introduced in 2006. The dose for men is half a cap twice daily. The foam does not have propylene glycol in it, so the foam is less likely to itch, but the efficacy is very similar compared to the minoxidil solution. The dose for men is twice a day. The dose for women is once a day. Oral finasteride is the most effective treatment for male balding, but it's the side effects of finasteride which limits its universal use for male balding. The drug is an inhibitor of 5-alpha reductase, and the drug reduces the levels of DHT in the blood by about 70%, and it reduces the levels in the scalp by about 50%. The medication stops hair loss in men in about 90% of males, and about 40% of men would be expected to get an improvement. The side effects of finasteride are very important to know about in prescribing this medication. The medication causes mood changes in a proportion of users, including depression. The sexual side effects are the most focused on, and they occur in anywhere from 1 to 4% of men, being more common in men over 40 than men under 40. Those sexual side effects include decreased libido, erectile dysfunction, ejaculatory problems. Gynecomastia can occur in about 1 in 300 to 1 in 1,000 men that are using the medication. It's important to remember that finasteride has undergone several post-marketing label changes since its FDA approval in 1997. And in 2011, the label changes included the indication that finasteride can cause persistent erectile dysfunction that continues in some men after the medication is stopped, and also male infertility or poor semen quality that did seem to improve after the medication was stopped. So it's very important to know about these and to advise your patients about the possibility of persisting dysfunction as well as the possibility of infertility. As well, although we don't have time to discuss it in greater detail today, it's very important to understand the concept of post-finasteride syndrome, or PFS, which is a constellation of physical and psychological, sexual and neurological symptoms that occur in some users of finasteride even after the medication is stopped. And so it is very important to understand these in detail if you're going to recommend finasteride in your practice. So when we return to this patient, the considerations that you may want to give are slightly different in a healthy patient versus a patient with depression versus a patient who wants to start a family. A patient with depression, finasteride presents a relative contraindication to starting finasteride. It may be possible to still start, but one needs to be aware of this. One needs to monitor changes in mood, and it may be for some patients that finasteride is in fact not an option. Finasteride can be used by men who wish to start a family and are trying to father a child. The important thing to remember is that finasteride can lower sperm count and create infertility in a proportion of men. And so any couple who is unable to get pregnant after a period of time, certainly one needs to consider that finasteride could be reducing sperm quality and creating infertility. What about your female patients? The thing that I'd like you to be aware of today is that the number of hair loss conditions that your female patients are likely to present with is much greater than your patients with male hair loss. Androgenetic hair loss is much less common in women at each of the age groups compared to men. And in evaluating a female patient with hair loss, it's very important to be able to differentiate between genetic hair loss, telogen effluvium or hair shedding, and alopecia areata. These are very important skills for you to have as a physician who's evaluating patients with hair loss. If your patient has something else that doesn't fit in these categories, you may consider referral. And so a very basic approach to treating hair loss and evaluating hair loss in women is the following. First, I'd recommend that you ask, is this alopecia areata, telogen effluvium, or female pattern hair loss? What you'll notice is that regardless of what you think the patient may have, ordering blood tests is absolutely paramount. All women with hair loss need blood tests, and we'll review some of the blood tests that are important to consider. If it's localized alopecia areata or telogen effluvium or female pattern hair loss, consider ordering blood tests and consider beginning treatments. We'll review some of the treatments in just a second. If it's female pattern hair loss, but the patient has irregular periods, or there's acne or hirsutism, or you think the patient has something else, you might consider ordering blood tests nevertheless and referring. And so we'll review these algorithms in a moment. The basic blood tests for anybody with hair loss is CBC, TSH, ferritin, and vitamin D. These basic blood tests are reasonable to consider in women with regular periods or postmenopausal women. Based on the patient's story or history, you may order other blood tests. If the patient has a history of autoimmunity, or there's things in the history which make you concerned, if they have headaches, photosensitivity, joint pains, you might consider ordering an ANA. Patients with gastrointestinal symptoms like diarrhea, you might consider ordering zinc. In patients undergoing bariatric surgery, I extend that panel to consider things like selenium and copper. So you're by no means limited to this panel, but CBC, TSH, and ferritin and vitamin D are your main parameters. Patients with regular periods, but acne and hirsutism, signs of hyperandrogenism, you might consider ordering a total testosterone, which is a measure of androgen function of the ovaries, as well as DHEAS, which is a measure of hormone androgen function of the adrenal gland. Patients with irregular periods, premenopausal women, it's important to consider ordering the following panel, which is done on day 3 to 4 of the menstrual cycle. And it's very important to consider the diagnosis of polycystic ovarian syndrome in patients with irregular periods and hair loss. Many patients with polycystic ovarian syndrome will first present to a dermatologist for acne or hirsutism, or to other clinics for diabetes or hypertension, but they may present for hair loss. And it's important to be aware of the appropriate workup for PCOS. I would encourage you to consider ordering some baseline blood tests even if you're considering referring this patient on to an endocrinologist or a gynecologist. These are the parameters that we often order. 17-hydroxyprogesterone is ordered on day 3-4 as well as part of the panel to evaluate for the rare congenital adrenal hyperplasia, which can very much mimic polycystic ovarian syndrome as well. So consider this patient, 29 years old, who has slow hair loss. The sites that are involved is the central scalp. She's shedding just a bit, but she doesn't have any symptoms. This is very much in keeping with androgenetic alopecia in women. Of these so-called 5 S's, the things that are important to be aware of in androgenetic alopecia in women are the sites that are involved. It's typically the central scalp as opposed to the temple and crown, which is more typical of men. Shedding is sometimes increased a bit in women with androgenetic alopecia, and that's very, very important to be aware of. Androgenetic alopecia in women can sometimes mimic a telogen effluvium, but generally patients have no itching or burning or pain, and generally it tends to be much slower than patients with classic telogen effluvium or androgenetic alopecia areata or scarring alopecia. So consider the treatment that you would consider in a patient who's healthy, and consider for a moment the treatment you'd consider in a patient with irregular periods and in patients who want to start a family. This is a female with androgenetic alopecia on the left side of the panel and a male with androgenetic alopecia on the right side of the panel. What you can notice first and foremost is that the pattern, the location of hair loss differs. Women with androgenetic alopecia develop hair loss more in the central areas of the scalp with a relative preservation of the very, very front of the scalp. Men, however, develop hair loss in the temples and the crown initially, and then the mid-scalp can be involved. We call it androgenetic alopecia in both, but the pattern of hair loss is very different. In women, these stages of hair loss follow a number of different stages, most commonly either the Ludwig stage or the Olsen pattern. Some women do follow a male pattern of balding, but that's the least common. In the so-called Ludwig scale shown here, you can see that there is progressive loss of hair in the central scalp as the stages of the Ludwig scale become greater. Men follow the so-called Hamilton-Norwood scale, where hair loss starts in the temples in stage 1 and then progresses to stage 7, where hair is lost completely in the front, middle, and crown, and just a thin rim of hair remains around the back of the scalp. The treatments for female pattern hair loss are shown here. It's important to remember that even in the present day, the only formally FDA-approved, Health Canada-approved treatment for female pattern hair loss is minoxidil. The other treatments are second line and third line. Minoxidil dosing is a half a cap once a day or 1 milliliter twice a day, and we'll review this in just a minute. Spironolactone is a second line agent. It is a common treatment for female pattern hair loss in premenopausal women. It can be combined with a birth control pill and frequently is combined with a birth control pill to prevent pregnancy. Spironolactone is class D and can cause birth defects in women using it who would become pregnant. So it's very important to counsel your patients about not becoming pregnant while on spironolactone. Dizziness, changes in libido, hair shedding can occur initially, breast tenderness can occur, changes in mood, dizziness. So it's important to be aware of how to prescribe spironolactone. We typically begin at 50 milligrams a day, working up to 100 milligrams twice a day, slowly over time. Finasteride can be used in menopausal women and postmenopausal women. The dose is generally 2.5 milligrams per day. A number of studies have shown that 1 milligram per day of finasteride is relatively ineffective in women with androgenetic alopecia. Dutasteride can also be considered in postmenopausal women as well. Side effects of finasteride would include changes in mood, changes in libido, depression. So it's very important to be aware of finasteride-related side effects as well. There is no good indication that finasteride increases the risk of cancer at the present time, but because of its effects on hormones, because of its effects on both androgens and estrogens, the presence of breast cancer, ovarian cancer, or gynecologic cancer may present a relative contraindication to finasteride, and so that's important to discuss with the patient and possibly with their oncologist as well. Low-level laser is also an option for treating female pattern hair loss, as is platelet-rich plasma. The use and benefit of these treatments is very similar in male androgenetic alopecia as well as female. Scalp micropigmentation and hair pieces are also an option for women. I'd like you to be aware that hair transplantation is less commonly an option for women. Of all the hair transplants that are performed yearly, about 85 to 90% are performed on men, 10% on women. And there's a good reason for that. Women commonly are not good candidates for hair restoration. Either they have miniaturization in the back of the scalp, which makes their donor area less suitable, or they have a widespread type of thinning whereby the placement of grafts into the front of the scalp just leads to less of a change, or they haven't developed significant amount of hair loss that would really lead well to hair restoration. Sometimes performing hair restoration in an area with too high of a density can lead to increased risks of shedding in women and further acceleration of their genetic hair loss. And so hair restoration in women is more challenging than hair restoration in men, and certainly if one is going to refer a patient for hair restoration in women, one should refer to a provider who performs hair restoration surgery in women quite commonly. Minoxidil is approved for use in women. The dose of the foam is a half a cap once daily. Side effects are similar. Shedding in the first 1 or 2 months, headaches, dizziness, heart palpitations. These can rarely occur in women. Hair growth on the face occurs in 1 out of every 20 women, and so important to be aware of as well. Here's a picture of a common response that we see in probably about 25 or 30% of women with androgenetic alopecia, not in everyone. So minoxidil does not work in all patients with hair loss, but you want to give it a good 6 to 9 months and preferably a year to determine if minoxidil is going to work. So it's a long time, but it does take that long to determine if the treatment is going to work. And here's a patient with a very positive response after using minoxidil. And so the approach that we'll take in this patient who presents with what we believe is female pattern hair loss is evaluating a full history. Do they have acne? Do they have regular periods? Do they have hirsutism? Do they have any other health considerations? Ordering blood tests. And if they have regular periods, then we might consider beginning treatment with minoxidil. A patient with irregular periods, as we saw, we can consider ordering that extended panel on day 3 to evaluate further for PCOS. There are many reasons for irregular periods other than PCOS, of course, and so we may consider referral to a gynecologist or endocrinologist to further evaluate the cause of those irregular periods. A patient who wants to start a family, we need to be aware that most of the treatments for female pattern hair loss are contraindicated during pregnancy. Low-level laser can be used, but minoxidil cannot be used during pregnancy. Spironolactone cannot be used during pregnancy, nor can PRP. And so one needs to be aware of this, and if a patient is planning pregnancy within the next short while, certainly I may not recommend the use of minoxidil or spironolactone or PRP, and we may start treatment with laser, or we may delay treatment. Let's take a look at some of the prototypical conditions that are associated with a rapid speed of hair loss, one of the so-called S's. Alopecia areata and TELOGEN effluvium are 2 conditions that can give a relatively quick type of hair loss. Let's take a look at this 16-year-old male who presents with hair loss over a period of 2 weeks. 2 weeks ago, he had complete hair. Full hair on his scalp. and now he has these distinct patches of hair loss. Alopecia areata can involve any site of hair loss, so it's not localized to any specific area. Patients sometimes notice increased amounts of shedding. Typically they don't have any symptoms, but they can develop a little bit of burning in these patches or itching before the patches develop. If you're going to treat alopecia areata, it's important to be aware of 3 definitions because your patients will want you to be aware of these. Alopecia areata refers to loss of scalp hair, but there is still some scalp hair remaining. If all of the scalp hair is gone, the appropriate term would be alopecia totalis. If all of the scalp hair, body hair is universally gone, the appropriate term is alopecia universalis. The treatment that I would like you to be aware of for alopecia areata is the use of topical steroids, minoxidil, and steroid injections. And I'd like you to be aware of how to perform steroid injections, and I'd like to encourage you to consider performing steroid injections. When performed properly, they can be quite effective and quite safe, and your patients will be very appreciative of your ability to help them in this manner in their alopecia areata as opposed to referring to a dermatologist. You may, as you begin, decide that you want to refer for eyebrows or other areas, but the scalp, you can often begin treatment yourself. So how do we treat alopecia areata? Remember that many of your patients will regrow their hair spontaneously within 1 year, even without treatment. So not performing any treatment is an option. But the first line treatment for alopecia areata with 1 patch or 2 patches is the combination of steroid injections, topical steroids, or minoxidil. Spontaneous regrowth is much less likely in a patient with 2 or 3 patches than in 1 patch. And so you may decide to begin treatment with a patient with many patches. In a patient with 1 patch, you may decide to begin a sort of a watch and wait type approach as well. But typically I may recommend treatment with a class 1 steroid like clobetasol propionate, either a lotion, a foam, or a cream. We might use it daily for a period of 8 weeks, then give the patient a period of time off the medication, say 2 weeks, and then repeat this cycle. I'll frequently have the patient apply minoxidil every night to this area of hair loss without a break, provided they're not using more than a half a cap of the minoxidil foam, or they're not using more than 1 milliliter of the lotion. This is a very good option. And we may have steroid injections at the same time. The other treatments are second line. There are many treatments that one can consider, and we use certainly all of the treatments on this list at some point in the clinic. My view is that treatments like DPCP, anthralin, methotrexate, prednisone are second line agents. My view is that for most patients, other things like the JAK inhibitors, tofacitinib, ruxolitinib, are third line agents. Despite their popularity, we have to remember that decades of use support the use of topical steroids, steroid injections, minoxidil for the vast majority of patients with alopecia areata. And so your patients may present with questions about the use of JAK inhibitors. There are certainly options, and we use them in the clinic, but these are not first-line agents for alopecia areata. I'd like to review with you how to inject steroids, because when done properly, they can be quite effective for many of your patients that present to you with alopecia areata. This condition affects 2% of the world. And so the vast majority of patients present with patchy alopecia areata. And so you have the opportunity to assist many patients with alopecia areata. And what I'd like you to consider as you begin injecting steroids is to begin with 2.5 milligrams per mil rather than 5, because this can be very, very helpful for your patients and presents an increased margin of safety in reducing the chance of atrophy and side effects compared to if you used 5 or 10. So to inject 2.5 milligrams per mil, first you get a bottle of 10 milligrams per mil, which usually comes standard. Get out a 3 cc syringe, put an 18 gauge needle on it, and draw up 0.75 mils of the triamcinolone acetonide. Then get out your saline and draw up another 2.25 milligrams. This will bring your volume up to 3 mils, and now you have a 2.5 milligram per mil syringe. You can make up another one, which will be 2, and these 2 syringes can be injected into the scalp. You'd put a 30 gauge needle on it, and you can perform steroid injections 1 centimeter apart, 0.1 mils in each of these zones. And so by using 2.5 milligrams per mil, you enhance your safety, you reduce your chances of atrophy or these indentations that can occur, and it can still be very, very beneficial. Who should you refer? Well, I would recommend you consider referring children who don't respond to either a watch and wait approach or children who don't respond to topical steroids. We generally don't do steroid injections in children less than 10, 11, or 12. It depends on the child. In adults, you might consider referring a patient who doesn't respond to 3 sessions of steroid injections or topical steroids and minoxidil. Let's take a look at some prototypical conditions that involve shedding. This is a patient who presents with massive shedding about 3 months after using a new medication. In this case, a medication, lithium. The shedding is everywhere. The shedding is marked. There can be 300, 400, 800 hairs per day being lost at its peak intensity. There may be slight tingling, but usually symptoms are relatively mild. And when you ask about supplements, you see that a new drug has in fact been introduced. And so the key about TELOGEN effluvium is the shedding and the speed of the patient's hair loss, but particularly the shedding. Patients with TELOGEN effluvium typically lose more than 100 hairs per day, but I'd like you not to be focused on the number of hairs per day because that's where people often get into trouble. If a patient says that, I can tell you, doc, I typically lose 30 hairs a day and now I'm losing 50, that's abnormal. If a patient used to lose 50 and now they lose 75, that's abnormal. And so we typically are focused on this number 100, but that's really not correct. Patients know their hair the best, and if they feel they're shedding more than their average, this is abnormal. What are the triggers of TELOGEN effluvium? The triggers of TELOGEN effluvium, I use the so-called SEND mnemonic. These are the things that send a delicate hair follicle from the growing phase to the shedding phase. The S stands for stress and scalp diseases. Things like the stress of a surgery, psychological stress, a death of someone in the family, severe emotional stress can trigger scalp disease. Severe scalp disease, like psoriasis, can also trigger shedding. Any endocrine disorder can trigger shedding. Hypothyroidism, the birth of a baby, these are common triggers of shedding. N stands for the nutritional issues, low iron, crash diets, bariatric surgery. These are well-known triggers of shedding. Drugs can trigger shedding. Any drug can theoretically trigger shedding. When clinical trials of medications are done, patients are given surveys to evaluate the side effects they experience. When patients fill out surveys about side effects, because hair loss is so common, invariably patients are going to report hair loss. So any medication can theoretically trigger hair loss, but certain medications are more likely, like lithium, beta blockers, antidepressants, some anticoagulants. How do we treat TELOGEN effluvium? We treat TELOGEN effluvium by identifying first and foremost the trigger. And if we can figure out what triggered it, then we fix that trigger. It's important to order some basic blood tests in anyone with TELOGEN effluvium. CBC, TSH, ferritin, and vitamin D are the first-line agents. But in a patient with TELOGEN effluvium, it's absolutely critical to perform a very thorough history. And that panel of blood tests that we ordered can be extended to a number of tests. ANA, zinc, VDRL, copper, selenium. The list can actually be quite extensive as you properly evaluate a patient's history. But the important point is that once you identify the trigger, if you can identify the trigger, the shedding will stop in most patients in about 6 to 9 months. One needs to be aware that in 50% of patients with TELOGEN effluvium, we can't identify the trigger. But if the patient's iron is low, we prescribe iron pills. If their thyroid is abnormal, we fix the thyroid. If you identify the trigger and fix it, the patient's hair loss likely improves. Who should you refer? Consider referring patients who have shedding that they're troubled with and the blood work is normal, or refer patients who have shedding and they have marked scalp symptoms like burning and pain. I'm often asked about patients who have shedding and all the blood work comes back normal. What do you consider in these patients? Remember that some patients with shedding are actually in the early stages of androgenetic alopecia. And so some of your patients who you think have a telogen effluvium actually have early androgenetic alopecia. So be aware of that. Some patients have chronic telogen effluvium. Some patients have this condition, CTE, where they continue to shed despite blood tests being abnormal. Blood tests being normal. That's very typical of chronic telogen effluvium. Some patients may have a scarring alopecia. Some patients may have diffuse alopecia areata. And so remember that some of your patients who present with what you think is a telogen effluvium may actually have other scalp conditions going on. Remember, they may have telogen effluvium, but you haven't identified the trigger. There's over 2,000 causes of telogen effluvium. Low iron, crash diet, stress, surgery, these are the most common causes. But remember, there are over 1,000 conditions in the body that theoretically could trigger a telogen effluvium, and we may not be able to diagnose those in all patients. The other non-scarring alopecia is traction alopecia. This patient on the left presents with early traction alopecia, where there's some hair loss along the front. This is due to the use of hair styling methods, including braids, weaves, cornrows, tight ponytails, man buns. These are common causes of traction alopecia. The woman on the left has traction alopecia as well. A biopsy was done, and that's why we see this small blue circle here. The thing that's so important to remember about traction alopecia is that early traction alopecia may be regrowable, but traction alopecia that's been around for many weeks or months may not be regrowable. There's no definite timeline that we give to that. But generally, if it's been 6 months or more with traction alopecia and the patient's not seeing an improvement, you may consider minoxidil or steroid injections or use of a cortisone, but the chances of regrowth go down quite a bit compared to someone who's just had hair loss for 3 or 4 or 5 weeks. Trichotillomania is another non-scarring alopecia which has many presentations. Again, trichotillomania in the early stages is identifiable, regrowable. This patient is a young child who presents with hair loss at the back of the scalp after severe emotional stress. If we can stop this child from pulling her hair, we can regrow the hair in a large percentage of patients. Many patients with trichotillomania, especially older individuals, 12, 13, 15, may have underlying depression, anxiety, obsessive compulsive disorders, attention deficit hyperactivity disorder. And so it's very important to perform a full history and consider referral in patients with trichotillomania who have these underlying emotional issues. Trichotillomania in very young children, 3, 4, 5, 6, can be more in keeping with a habit and is less associated with these severe underlying psychological disorders. Finally, what about the S that's associated with symptoms? This is a patient, 65, who presents with itching, burning, pain in the scalp. The speed of the hair loss is moderate. The hair loss is occurring more in the central scalp, but patients with scarring alopecia like she has can have hair loss anywhere. She may be shedding a bit more than normal, but the predominant S in these 5 S's is the symptoms. The thing I'd like to leave you with is that patients with severe burning and pain, itching as well, but especially burning and tenderness and pain, should really have referral to a dermatologist to rule out the possibility of a scarring alopecia. These scarring alopecias are a diverse group of conditions, and we saw the list in the beginning. Things like lichen planopilaris, frontal fibrosing alopecia, discoid lupus, central centrifugal alopecia. These are generally autoimmune in nature, and they're treated with various anti-inflammatory agents like topical cortisone injections, as well as various immunosuppressant agents as well. But a biopsy is frequently needed to exclude scarring alopecia. You will see many patients with red scalps. There's a multitude of causes of red scalp. Certainly most patients who are itchy and have a red scalp, you need to consider things like seborrheic dermatitis. Dandruff is a close relative of seborrheic dermatitis. Seborrheic dermatitis presents with scalp redness, greasy scale. Patients develop itchiness, especially if they've gone many days without washing their scalp. Psoriasis is also common. And so these are the most common causes of a red scalp. But remember, scarring alopecia, autoimmune diseases also need to be considered. And so consider referring patients for a biopsy in patients with a red, itchy scalp that's associated with hair loss. If you're comfortable performing biopsies, it's a valuable skill to know how to do, but it has to be a 4-millimeter punch biopsy, and it has to be taken from the right area, the area which is showing these key morphologic features of the disease you think the patient has. A random biopsy anywhere on the scalp is not useful, and so you may consider referring a patient for a scalp biopsy. And so the approach that I would recommend that you consider in women, again, is determining if you think it's androgenetic alopecia or alopecia areata in a localized form or telogen effluvium. Always order blood tests. If the patient's androgenetic alopecia is associated with some signs of hyperandrogenism, or you're just not sure what this is, consider referral to a dermatologist. I'm going to leave you with one more case, which I think is a very important point to be aware of, and that's chemotherapy-induced hair loss. This is a 42-year-old female who has a history of breast cancer. She completed her chemotherapy a year ago, but her hair hasn't grown back fully. She developed hair loss a few months into the chemotherapy. She was on a taxane. She was waiting for her hair to grow back, and it didn't grow back completely. And I'd like you to give thought to how this situation differs from a patient who's about to undergo chemotherapy and wants to know how she can prevent hair loss. These are two different situations. These two situations are different because they allow you to think carefully about two scenarios. One is transient chemotherapy-induced alopecia. The second is permanent chemotherapy-induced alopecia. Transient chemotherapy-induced alopecia is probably what you're most familiar with. It's the type of hair loss that about 2/3 of patients who are undergoing chemotherapy experience. We expect that within weeks of chemotherapy that hair loss will develop, but we expect hair to grow back within 6 months after their chemotherapy. That's what we expect. Permanent chemotherapy-induced alopecia is a type of hair loss where the hair does not regrow back to the same thickness after the patient's chemotherapy is done after 6 months. Permanent chemotherapy-induced alopecia is becoming recognized now as occurring with a number of chemotherapy agents, but especially with the taxanes that are used in the treatment of breast cancer. There are a proportion of women that are developing permanent chemotherapy-induced alopecia, whereby they don't quite get back all their hair after chemotherapy. For some, it's a mild amount of hair loss. For some, it's a marked amount of hair loss. But in the transient chemotherapy-induced alopecia, the first scenario, I'd like you to be aware of these new FDA-approved agents called the scalp cooling agents, which are now known to prevent chemotherapy-induced alopecia. And these have led to quite remarkable changes in how patients undergoing chemotherapy are treated. There's 2 FDA-approved devices shown here in this picture. The DigniCap was approved in 2015, and the Paxman device was approved in 2017. These 2 scalp cooling devices can reduce the chances of women developing hair loss in the first place after chemotherapy. And these studies that led to their approval show that they can reduce noticeable hair loss or hair loss that would otherwise prompt a woman to wear a wig in a significant proportion of people using these scalp cooling devices. So they're important to be aware of. We can, in some women, reduce the chances of hair loss after chemotherapy. We don't yet know how we can reduce the chances of persistent chemotherapy-induced alopecia, and this remains an ongoing subject of research. In conclusion, anybody who presents with hair loss, consider please ordering CBC, TSH, ferritin, and vitamin D. Other blood tests may be relevant, but they're guided by the patient's history. Minoxidil remains the key starting point as a first-line agent for female androgenetic alopecia. Minoxidil and Finasteride are important first-line agents for androgenetic alopecia in males. Topical steroids, steroid injections, minoxidil are first-line agents for alopecia areata. I'd like you to give thought to the possibility of using steroid injections at 2.5 milligrams per mil in limited amounts in your patients with alopecia areata in patchy form. It can be tremendously helpful for your patients, and by reducing the time that it's required for referral to a dermatologist, you may be able to assist these patients tremendously and assist them with hair growing back. Consider referring patients with burning and pain in the scalp. These are symptoms which may indicate a possible scarring alopecia or underlying issue. Of course, they may have seborrheic dermatitis, they may have psoriasis, but you have to have a heightened awareness for a larger differential diagnosis in patients with scalp burning and pain. With that, I'd like to conclude. I'd like to thank you very, very much for your attention, and I hope this presentation was useful.